Okay guys, so this is the series of videos on Salam mocks. Every video will contain one station or one mock. Mm, so you can follow it under the playlist Salam mocks by Salah. So this is transfer bleeding station, and the stem is 6-year-old Joa witness with secondary hemorrhage post of day 6 after tonsillectomy. Heart rate is 120, but the patient is stable now. If HB is 7.4, how will you manage, or will you give blood since HB is 7.4 and in acute bleeding? Transfusion starts at less than 9, but the patient is stable and duo witness. So in acute cases, we or in acute bleeding, we give HP, sorry, transfusion or blood in when there is 9.9 HP. But since the patient has a 7.4, so and he's dual witness, I will start resuscitation with colloids and crystallites other than blood until I get consent from the parents. So here is the indication, but you have to get consent because this is dual witness. If they refuse, I will inform my consultant and legal team to get court order to start blood transfusion in the best care of the patient. How will you manage the airway? I will start by assessing the airway. Sorry for the, now it's better. Okay, so I will start by assessing the airway, look, feel, listen, and call for help from ANT. And if foreign body blood clots are found, I will try to remove any through suction to open the airway, chin lift and jaw thrust if needed to maintain an open airway. If failed, an air not patent or pharyngeal or nasopharyngeal airway in oxygenation. If failed, intubation by expert. So this is ABCD CRISP protocol. How to stop bleeding in theater? Packing with adrenaline soaked gauze or surgical, bipolar cautery under running suture. So first of all, always we do pressure packing. So if it's not possible, then we can do it surgically by bipolar cautery under running sutures. Take a hemostatic suture of figure of 8 and gel foam. Medication, you can give transamine 500 milligram or 1 gram or according to it. Last option is external carotid ligation if bleeding cannot be controlled. The tonsillar artery is usually involved in it, so it's coming from the external carotid artery. So type of diathermy, bipolar diathermy. Which medication will help dose transamic? Okay, I said 10 to 15 milligram per kg, or in old setup we use like 500 milligram or 1 gram. What will check when the patient is in recovery? HP level. Calculate bolus dose. Use glucose-free crystallites that contain sodium in the range of 131 to 154 millimole per liter with a bolus. Normal sodium is 135 to 154. So you can give this with a bolus of 20 ml per kg or less than 10 minutes. 20 ml per kg or less than 10 minutes for children and young people. Glucose-free crystallites, or in 15 minutes you can say. Calculate maintenance dose. Using Holiday Sager formula, 100 milligram per kg per day for the first 10 kg of it, and then 50 milligram per kg per day for the second 10 kg of it, and then 20 ml per kg per day for the weight or 20 kg, or like after 20 each kg will get 20 ml, and for the first 10 kg each kg will get 100. For the next 10, 50 ml per kg, and then 20 ml per kg, so on. Be aware that over 24-hour period, males rarely need more than 2500 ml and females rarely need more than 2000 ml. Using surface area, range is 300 to 400 ml per meter square per 24 hours. 300 to 400. So how will you make sure you are operating on the correct patient? WHO checklist. What is the sign in, timeout, and sign out? They are parts of the WHO checklist. Sign in before induction of anesthesia, and time out before skin incision, and sign out before patient leaving the operating room. Okay, so this was the station.